Well, it's super to have in-person meetings again, because these online stuff, it's okay, but you miss the sparkle, so happy to be back. The issue with TAVI is that we're still treating elderly patients, and you always have to balance the risk of bleeding with the risk for thromboembolic events. And so we recently published the ENVISAGE TAVI AF trial, which randomized patients who had atrial fibrillation after a TAVI procedure, and they were randomized to a vitamin K antagonist or edoxaban, which is one of the non-vitamin K oral anticoagulant drugs. The main findings were basically, there was no difference in the net adverse clinical event rate, but we did see more bleedings with edoxaban as compared to vitamin K antagonists. And now the question was, okay, but why would that be? And we only presented the intention to treat analysis. At London Valves, we presented also the on-treatment analysis, basically looking at what were the patients actually taking while they were having the event. So this is a more in-depth focused view on bleeding events in these patients. What we did find is that indeed we did see more bleedings with edoxaban, but the issue there is that we're really treating elderly patients. So the mean age was in the early 80s. And the thing is that the bleedings were predominantly driven by GI bleedings, gastrointestinal bleedings, but also in the group of patients who were receiving not only oral anticoagulant drug therapy, but also antiplatelet drugs. And I think the combination of oral anticoagulant and oral antiplatelet drugs in patients after a TAVI procedure, that's not the way to go. And as a matter of fact, updated ESC guidelines also recommend against it. So if a patient requires oral anticoagulant drugs, you should not be combining it with antiplatelets. And of course, sometimes you have to because the patient received a stent, but then you also need to be very considerate about dose reduction criteria, for instance. So that is the important message. Don't combine oral anticoagulant drugs with oral antiplatelets if it's not really necessary. And if patients are taking, for instance, edoxaban, also be careful with dose reduction criteria and respect them. We presented the 5-year outcome data of SURTAVI, and this is an important landmark because we will continue the follow-up out to 10 years. But at 5 years in elderly patients, because the mean age was 80 years old of these patients, was that there was no difference whatsoever in the primary composite endpoint of mortality or disabling stroke. We did have some indications from other trials that there might be more events between 2 and 5 years with TAVR as compared to surgery, but that did not happen in SURTAVI. So this was a very reassuring finding. So if you, for instance, look at valve thrombosis or valve endocarditis, there was no difference between the two treatment arms. And if we look at the need for reintervention, valve reintervention, we did see more reinterventions in the TAVI arm, but those were all early after the procedure. So if you look at the need for reintervention between 2 and 5 years, no difference whatsoever. There were only 6 patients in the TAVI arm versus 7 patients in the surgery arm who required a valve-related reintervention. And that is really reassuring also in terms of valve durability. There was no signal that one valve was performing worse than the other. So that is quite an important finding. First of all, I think there is a lot of research ongoing on the value of embolic protection, cerebral embolic protection. I think if we move to lower risk patients, if we can improve outcome and even reduce further the risk of cerebral embolization, we should do that. But we are awaiting randomized trial data. And then, of course, the important question in lower risk patients is the durability. We now have reassuring data out to 5 years, but we really need follow-up out to 10 years. The issue is that the intermediate risk patients were around 80 years old when they entered the study. So 10 years down the road, they will be 90. So of course, nature is catching up. So we won't have a lot of patient data out to 10 years, probably. Fortunately, we have the low-risk trials, and the mean age of the patients was 74 years old. So those trials really will give us a more definite answer in terms of valve durability.